Hello, ladies and gentlemen. Welcome to Triple N Media Talk Show. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. This is COVID 19 pandemic world news. In this presentation, we are going to look at the hydroxychloroquine Henry Ford study that was reported in July 2020. Let us begin. As of July 18, 2020, there are more than 14.3 million cases of coronavirus infection all across the globe, with more than 600,000 deaths and 8.57 million have recovered from the coronavirus infection. Now we are going to look at the role of hydroxychloroquine, especially Henry Ford study. Since there is no specific treatment for coronavirus infection, multiple drug therapies have been tried to reduce the viral duplication, to reduce the effect of the virus on the lung tissue. And one such study is hydroxychloroquine. Hydroxychloroquine has been used in different parts of the world with varying results. Conflicting results have been obtained here in the United States with the use of hydroxychloroquine. However, this study looks at the role of hydroxychloroquine in a systematic fashion. This was reported by the Henry Ford COVID-19 task force led by Samia Ashrad. This study evaluated the role of hydroxychloroquine therapy alone or in combination with azithromycin in hospitalized COVID-19 patients. I want to underscore the word hospitalized COVID-19 patients. We'll come back to that. And here's the reference to that article in the PubMed. Before we go any further, let us first find out what is hydroxychloroquine and how does it work. Hydroxychloroquine is an anti-malarial drug which is also used as an immunomodulatory agent in patients with immune-related arthritis like lupus and others. Hydroxychloroquine acts as an antiviral agent against SARS-CoV-2. It exerts its antiviral activity by increasing the intracellular pH, resulting in decreased phagolysosome fusion, impairing viral receptor glycosylation. It also decreases production of cytokines, especially interleukin-1 and interleukin-6, by inhibiting toll-like receptor signals. It may also have a potential antithrombotic effect, all of which benefit patients with COVID-19 infection in terms of reducing the immune response to the viral infection, reducing the movement of virus into the cells in the lung tissue. Anyway, the study period was from March 10 to May 2nd, 2020. There were 2,541 patients with a mean hospitalization of 6 days. The hydroxychloroquine dose included 400 milligrams twice daily on day 1, followed by 200 milligrams twice daily for 2 to 5 days. And an important thing we want to underscore here is that 92% of the patients received hydroxychloroquine within the first 48 hours after the admission to the hospital. That is an important factor to keep in mind. They also very closely monitored the QTC intervals, and in those patients who had QTC greater than 500 milliseconds were very carefully monitored, and they minimize the use of hydroxychloroquine in patients with significant cardiac problems. The other treatments included corticosteroids and tocilizumab. Here is a breakdown of the study group of 2,541 patients. They were divided into 4 groups. The first group, which received neither hydroxychloroquine nor azithromycin, that number was 409. 1,202 patients received hydroxychloroquine alone, whereas 147 received azithromycin alone, whereas 783 patients received a combination of hydroxychloroquine and azithromycin. And here is the mortality, which we are going to go into in detail. I just want you to look at some of the demographics of these patients so you get a general idea as the variety of comorbid conditions these patients had. In fact, most of these patients were from Detroit area, and they reported a very high incidence of comorbid conditions, which we'll talk about in a couple of minutes. As you can see, BMI, more than 50% of the people had a BMI of greater than 30. In addition to that, they also had significant lung disease, 63%. Cardiovascular problems was considerably less. 43% of the patients had chronic kidney disease. And here are some more findings as far as the ICU stay. Remdesivir was just coming into the market during this study, and less than half a dozen people received the remdesivir in this particular study. Now let's look at some of the outcomes in this study. The overall mortality was 18.1%. That is a significantly higher number compared to what we generally see in other hospitals across the country. And we will come back to that point in a minute. Those patients who received hydroxychloroquine and azithromycin had a mortality of 20.1% compared to those who received hydroxychloroquine alone, where the mortality was 13.5%. And look at those who received neither drugs had a mortality of 26.4%. Look at the difference between the group that received no drugs versus the group that received hydroxychloroquine alone in the first 48 hours following the admission. The mortality in the hydroxychloroquine group alone was 13.5% compared to 26.4% in the group that received neither of these 2 drugs. This is a dramatic difference for the first time, where we are seeing a substantial decrease in the mortality of the patients who are treated with hydroxychloroquine alone within the 48 hours after admission to the hospital. And here are the Kaplan Meier curves showing the hydroxychloroquine group represented here in green compared to the red, which is the group that received neither of these 2 drugs. As you can see, the mortality was considerably lower in the hydroxychloroquine group alone compared to even hydroxychloroquine and azithromycin group. Similarly, the azithromycin group had a much better mortality when it was given alone compared to those who did not receive the azithromycin as a treatment option. So these differences are significant, and we're going to look at them in a little more detail. The predictors of mortality in this particular group included age greater than 65 with a hazard ratio of 2.6, white race with a hazard ratio of 1.7, and chronic kidney disease with a hazard ratio of 1.7, reduced oxygen saturation, which basically suggested significant decompensation in the lung function and tissue, with a hazard ratio of 1.5, and those who were placed on ventilators had double the risk of dying during the hospital course. Surprisingly, in this study, the BMI did not make a significant impact on the risk of increased death, which is contrary to some of the other studies we had seen where there was increased death in the group with the obesity as one of the risk factors. All right, so if we look at some other conditions that were reported here in this Cox regression, we already saw this hydroxychloroquine, which had a hazard ratio of 0.34, which is one of the best ones we have seen in any hydroxychloroquine study that has been reported to date. Again, there was the Zithromax alone showed some improvement compared to the group that received no treatment. So in conclusion, hydroxychloroquine alone and in combination with azithromycin was associated with reduction in COVID-19 associated mortality. They related the benefit of the hydroxychloroquine to its use early on during the course of the COVID-19 infection, and also to the standardized dosage and regular monitoring of these patients. They postulated that later therapy in patients who have already experienced hyperimmune response or critical illness were less likely to benefit from hydroxychloroquine, and it may have been partially responsible for a higher mortality in patients who received hydroxychloroquine at varying time intervals from the time of onset, from the time they were admitted to the hospital. Let's look at some counterpoints. The authors themselves said it was a retrospective, non-randomized, non-blinded study design. They concluded we needed prospective trials to examine this impact on a larger scale. Surprisingly, they did not have significant cardiac events. There was no record of torsade in their patient population. As we saw, the number of cardiac patients were small in this particular group. They postulate that cardiac events develop later on during the course, and early treatment with hydroxychloroquine may perhaps reduce cardiac inflammation. One interesting thing that they reported was that the ICU mortality in Detroit in their study was 45%, and this was related to the number of comorbid conditions which we already talked about. And they cautioned that it does not apply to patients treated outside the hospital. This is an important study as far as looking at reducing the mortality in patients with COVID-19. There has been no other study which has shown such a significant drop, almost 66% drop in overall mortality in the patients group treated with hydroxychloroquine alone. But this is not the final answer as far as hydroxychloroquine is concerned. This is in line with the NIH recommendation for a controlled, randomized, double-blind study to really look at the effects of the hydroxychloroquine in patients with COVID-19 infection.